p.m. So I think we can start now. Today, we're honored to have Dr. Danny Yakoub from Mayo Clinic Health System in Wisconsin, USA, who will be talking to us today about lymphadenectomy for gastric cancer. Thank you, Dr. Danny, for joining us, and the floor is yours.
Thank you very much, and I appreciate the opportunity to present among my teachers and professors. We're going to talk today about lymphadenectomy for gastric cancer. I'll run through a few slides in the beginning as an introduction to gastric cancer, and then focus on the subject that we're here for, which is the lymphadenectomy. So as we know, the stomach is a very vascular organ supplied by at least 5 blood vessels, including right and left gastric, right and left gastroepiploic, in addition to the short gastric vessels. And alongside those, there are veins and the lymph nodes, which are the subject of our discussion today. The lymph nodes have a specific way of drainage. Each part of the stomach drains in a particular direction. Nevertheless, when we operate on the stomach, we consider all of them as interconnected. So when we do a lymphadenectomy, we do it throughout most of these groups together. We know the layers of the stomach wall, which is an important piece of information because once we pass the mucosa into submucosa, that's when we get access to the lymphovascular structures, and therefore we can reach lymphatic spread. And that's why early gastric cancer in the T1A and T1B is treated by EMR and ESD, because it has less than 1% chance of metastasizing to lymph nodes, and therefore can be excised by just resecting the mucosa. Anything extra to that then needs a gastrectomy, and we add to that the lymphadenectomy with different extents. As an epidemiology, a little over 750,000 cases globally each year. In the United States, somewhere between 20 and 22,000 cases per year. Cumulative risk of death in males is 1.36, and in females is a little less. So it's a worse cancer in males than females. The mortality overall from gastric cancer has significantly decreased the past 75 years for unknown reasons, and it stayed as such. 50% of cancers are in the antrum, 30 in the body, and 20 in the fundus. In Western Europe and USA, the histological type predominantly changed between it used to be intestinal variety, and now it's more the diffuse type. The shift in both the absolute and relative terms towards the GE junction area as a primary mucosal origin cause for it, and 65% at presentation are either T3 or T4 tumors, while 85% at presentation have lymph node metastasis, and 30% of patients have liver metastasis. This is just a distribution showing different countries or continents, but we can see the vast majority of cases, or the highest incidence, is in China, and followed by the rest of Asia, and then in Europe. Africa fares fairly low amount of gastric cancer for some reason. As we know, the first successful gastrectomy was done in Vienna in 1881 by Billroth. The risk factors, I'm not going to go through them, but some of them are environmental, some of them are genetic, and some of them due to precursor conditions as listed here. Genetic analysis of different tumors showed that each of the progression from normal to carcinoma to metastasis involves largely one or more of the genetic mutations as seen in this figure. 85% of gastric tumors are adenocarcinomas, while 15% are others, including GIST, lymphomas, and carcinoid tumors. Classifications, we have the macroscopic Borman's classification is how it shows on endoscopy or how it grows, which is the polypoid, the ulcerating, the infiltrating, and the diffuse infiltrating. And they actually go in that order of badness, if you may. And then we have the microscopic, the Lauren classification, including the intestinal type, as we discussed, that used to be the most common, and now the more common is the diffuse type, which is the Linitis plastica, and some people correlate that with E-cadherin positive patients, and those are the same patients who have invasive lobular carcinoma of the breast. The differences between the diffuse and the intestinal, we can see the survival in the intestinal. Can you see my cursor or no? When I do with the cursor, can you see it?
Yes, we can see it.
Okay, so the 5-year survival in diffuse type is in all comers is less than 10%, while the intestinal is a little bit better, somewhere in the 20%. And we can see that H. pylori plays an important role in both of them, and therefore chemo prevention is a big deal these days, because it kind of may have contributed to decrease in the incidence. As we know, the spread goes either direct spread through the wall to adjacent structures, the pancreas, the liver, the diaphragm, lymphatic spread to lymph nodes, hematogenous spread to the liver and lung and others, and the transcoelomic biperitoneal carcinomatosis. Symptoms and sign, very mostly abdominal discomfort, sometimes weight loss, and sometimes if they are bleeding with melena. Signs, very rarely, if you feel an abdominal mass, it's already too late. If it spreads through lymphatics, the Virchow's lymph node in the left supraclavicular, or Sister Mary Joseph nodule in the umbilicus, or it can be found on other detection like a Krukenberg tumor or through finding ascites. This is an overall format of how we work up those patients: endoscopy to localize and biopsy. Biopsy will give us the diagnosis and we'll do the genetic testing. And now we added a couple more, which is the HER2 status and the PD-L1 status, because that has become part of the therapy, second-line therapy for metastatic disease. And then we do an EUS. The EUS functions to specify which T stage is it, T1, 2, 3, or 4. And there are computer programs that can actually work on the findings of the EUS to direct the treatment from there, depending on the thickness and other findings, including lymph node involvement. If it's a T1, T2 disease, directly surgery can be considered, despite that all the trials have shown that neoadjuvant chemotherapy improves the outcome. If it's T3 and T4, we have to complete the rest of the staging for the lung mets and others. A PET scan can be considered, despite that it's not always positive in gastric cancer, especially in signet ring cell types. A diagnostic laparoscopy with peritoneal washings is now a must before all of them. Before we give neoadjuvant chemotherapy, we do a diagnostic laparoscopy, because if it's positive, then we change the regimen into a palliative regimen. If it's negative, then we proceed with neoadjuvant chemotherapy and then surgery after that. This is a picture showing Linitis plastica. Two staging systems, the AGCC and the and the Japanese classification. The more elaborate one is the Japanese one because it's more anatomic based, and it actually identify which lymph nodes are enlarged and how close they are to the primary tumor, as opposed to the Western system, the AGCC. Depends on whether there are lymph nodes positive or not, regardless of how they locate close to the tumor. The T stage, unlike different other tumors, depends on the depth of invasion, not 0 to 2, 2 to 5, and more than 5. It like other tumors, it's actually mucosal, submucosal, and subserosa or serosa, or invasion of other structures. The workup, as we said, includes CT scan. It can include also PET scan. I wanted to show a couple of pictures of endoscopic ultrasound and how it can show the 5 layers of the gastric wall. You can see the mucosa, submucosa, the musculosa, the subserosa, and the serosa. And depending on where the tumor is, it can. This is a normal picture. This is a picture with a tumor. You can see the T sign signifies a tumor, and this one shows a T3 tumor which is involving more than 4 layers of the stomach, while this, despite it being a big tumor, but it's invading only 1 layer and showing that the second layer is intact. So that's a T1 tumor. This is how accurate EUS can be. And it can also show lymph nodes and biopsy them. PET scan, as discussed, may or may not show uptake, but it definitely shows if there is distant metastasis in the liver, lung, bone, or otherwise. There are some serological markers, including CAA, CA125, CA19-9, CA72-4. All of those can be done, but they are not sensitive or specific, so we don't really do them, at least here. None of them is diagnostic. If one of them has been done and shown to be high, it can be followed for responsive treatment. There's a picture showing peritoneal deposits. And this is quickly the TNM staging. I'm not going to go through that. Treatment for locoregional disease, which is stages 1 to 3, according to the TNM, those are potentially curable. All cases has to be discussed in an MDT meeting and can be considered for surgery, but more likely to have neoadjuvant chemotherapy and then surgery. Obviously, stage 4 disease is palliative treatment, whether it's palliative chemotherapy or palliative surgery by bypassing, or in some cases, if they bleed or obstruct, they can be resected, but for palliative intent. There is an emerging role of hepatic metastasectomy if there is oligometastasis that's responsive to chemotherapy. We went through that. And the most common therapies used for neoadjuvant is ECF, ECX, and FLOT, and that's per the MAGIC trial results that was done in England. We're going to talk about the complete surgical treatment for the earlier cases, stages 1 to 3, which will include the lymphadenectomy. The reason we do lymphadenectomy, because about 25% or 26% of recurrences come locally, as opposed to some other cancers where you get the recurrence as metastasis in the lung or liver. These come locally, and therefore extensive local ablation of the tumor, if you may, surgical ablation, is necessary. Exclusion of peritoneal involvement in the beginning and during the treatment is necessary to get a successful treatment. This is histological positive margins on how much of the stomach we need to get, and it shows that if we get more than 60 millimeters of proximal margin and at least 2 after the pylorus, we get almost a 0% chance of histologically positive margins. You know the reconstruction, either a subtotal gastrectomy with a B2 or even a Roux-en-Y, or a total gastrectomy with a Roux-en-Y, and these are pictures. There is an operation which is the proximal gastrectomy, with pull-up of the stomach and anastomosis of the esophagus. As much as it can be done, it's not a very good operation because it has a lot of reflux, because you have to do a pyloroplasty with this, and then you got bile coming out the esophagus, causing severe esophagitis. So it's not a very good operation. EMR and ESD, as I said, done for T1 disease, less than 2 centimeters, node negative, and it's very successful when done. And this shows the effect of perioperative chemotherapy on outcome. This is the outcome per stage. As we can see, it's very uniform. The higher the stage, the worse the prognosis. And finally, inoperable tumors, as we said, can be, we can do a bypass or just a gastrostomy tube. Survival for stage 4 is less than 6 months. And finally, we'll talk about the part regarding the lymph node dissection. Lymph nodes around the stomach have been designated as stations, and those stations go by anatomical region. They've been numbered between 1 and 12. And once we get outside that area, even towards the superior mesenteric vessels and aorta, go to 14, and then to the aorta go to 16. And those are the numbers. There's just a sequence of some of those numbers. But in short, we have group 1 or station 1 to the right of the esophagogastric junction. 2 is to the left. 3 is the lesser curves, and you can divide them to 3A and 3B. And the distinction between them is the third vessel going into the stomach. And then you have group 4 over the greater curvature, and they go from 4SA with the short gastric vessels, 4SB with the left gastroepiploic, and then 4D with the right gastroepiploic. And then at the base of the right gastroepiploic, there is the suprapyloric and the infrapyloric 5 and 6. And then you go backwards towards the celiac axis. You have group 7 by the left, the base or the root of the left gastric artery, group 9 by the celiac axis, and then group A by the common hepatic, 8 by the common hepatic artery. And then if you go up the common hepatic artery, you'd find group 12A and 12B, depending on the side. As I said, there is a group 13, which is like inferior pancreatico-duodenal, and group 14 by the SMA, and then group 16 by the para-aortics. The theory behind going after lymph nodes is 2 theories. There is the anatomical theory that you're getting a negative margin if you remove all the lymph nodes that include any metastasis in them. And there is the biologic theory that lymph node metastases are prognostic markers, and they just show us that this is a bad disease that can spread rapidly. So the extent of surgery that we can do, as we said, either an EMR or ESD, which is the endoscopic submucosal dissection. And then there is the gastrectomies. There is the gastrectomy, the partial gastrectomy with a D1 dissection. A D1 dissection includes the immediate lymph nodes around the stomach. Some people described it as the first 3 centimeters around the margin of the stomach, which basically divided D1 dissection to D1 alpha and D1 beta. D1 alpha is you take around the stomach. If you take around the stomach, you're taking 1, 2, 3, 4, 5, and 6. Those are the ones immediately. I'm gonna go to the previous slide, and if you look here, 1, 2, and then 3, 4, and then 5 and 6. That takes away the ones right next to the stomach. D1 alpha, which is a little bit more than D1, you take the left gastric lymph nodes, and D1 beta, you take the left gastric and some of the celiac and the beginning of the common hepatic, which are add group 7, 8A, and 9 to the first 6 groups. Now you go up to D2 dissection. You take all what was taken in D1 plus beta, and then you add to that group 12A, which is the hepatic artery proper, and sometimes group 10, which is around the splenic artery. D3 dissection, which we don't recommend or do, is D2 plus para-aortic lymph nodes. This is in short the description of each of the groups that can be removed. The first echelon is the D1, the second echelon, which is the stuff around the stomach in addition to left gastric and celiac axis, and then D3 if you go to the para-aortic, retropancreatic and retroduodenal. D4 has even been described if you go down the para-aortic lymph nodes. This is a concept that have been introduced earlier in the century, like in 2002 and 3, is the precision lymphadenectomy concept. Rather than the D1, D2, is to see where the tumor is and assume the lymph nodes that would be draining that group of lymph nodes and take those out. This didn't take off because of high rates of local recurrence, but it's still considered as an acceptable option in early gastric cancer, like a T1A or T1B, that you're going to do a gastrectomy without chemotherapy, and there is no evidence of any lymph node enlargement. Then precision lymphadenectomy can be included, and people support that you should do lymph node mapping, something similar like sentinel lymph node, but it's not sentinel, it's just you put a dye in the tumor and you see it going to the lymph nodes, or a nuclear material like technetium-99 and see them intraoperative, and then decide on the lymph node stations that you're gonna remove. Again, this didn't take off and it's hard to apply, and it's hard to train people on. And finally, the D2 lymphadenectomy, and it's a picture to show the real lymph nodes that we're gonna be going after for a subtotal and a total gastrectomy. This figure shows the recommendations for a D2 gastrectomy. Remember, if there is a tumor down in the gastric antrum, is it worth taking stage 1 and 2, which are paraesophageal? If you have a cardiac tumor like 5 centimeters from the EG junction, that's considered like Seward type 3 or a gastric cancer. And is it worth going down and taking 5 and 6 and the hepatic artery lymph nodes? That is the argument. Like, should you go after these? Because the more lymphadenectomy you do, the more morbidity you can lead during your surgery. So this is was a consensus recommendation all over Europe, done by one of the Italian groups, to show what's the recommendation of a D2 lymphadenectomy in those situations. So we can see, like in cardiac tumor, even in a T1 tumor, 50%, 55% of the surgeons in Europe, or at least those who responded to the survey, recommended to do a D2. If it's a linitis plastica, 94% suggested a D2, and you can see even in the antral tumors, which are sometimes looked at as a little bit different than the fundic tumors, that they can be operated upon even sooner without chemotherapy, but still most of the surgeons, over 80% in all comers, even in early tumors, recommended a D2 gastrectomy. The argument between those who are proponents of a D2 gastrectomy and those who are opponents of a D2 gastrectomy. First of all, in the West here and in America and in England, they call the D2, why are you doing it? You're doing like cherry picking. And it's not going to make a difference in survival. So the people against it say advanced disease is not amenable to surgery anyway. So why do this? And if the cancer has already spread to lymph nodes far away from the primary tumor in the hepatic hilum, it's already biologically predetermined that it's a bad tumors. Then why do it? Just give chemotherapy. They also say survival advantage of radical surgery merely an artifact of more accurate staging, low stage migration. Basically, if you get more lymph nodes, then you know how many are involved. You could catch the very last lymph node that had a metastasis, and therefore you can direct post-operative chemotherapy, and then you get better survival. So they're arguing it's not the lymphadenectomy that did it, but the chemotherapy. They argue also that it's excess morbidity and cost of longer operating times, and not every surgeon is trained to skeletonize those vessels or is comfortable to doing that. While back in Japan, they argue the opposite. They say that the survival depends specifically on nodal stage, and removing all the lymph nodes involved is kind of a negative margin surgery, despite that it's not the stomach margin, but consider it the lymph node margin. It removes occult nodal disease that could be the source of distant metastasis later on. It achieves better loco-regional control, and it's a superior and more extensive surgery, and therefore the surgeons doing it do a better job at the whole operation and has a better survival. Now, did this translate into numbers, into survival? The answer is yes. However, the NCCN recommends 16 lymph nodes removed with the stomach for appropriate staging. The Japanese Gastric Cancer Association recommend a D2 gastrectomy for any T2 or higher, while in the West here we rarely, or they rarely, suggested for T3 or only for T3 and T4. Again, this is the lymph nodes removed. We'll get a little bit into the technical aspect of the lymphadenectomy. So the operation starts by getting into the bursa. And the bursa is basically the combination of the omentum covering the posterior aspect of the stomach and the inside of the greater omentum above the colon and the top of the transverse mesocolon. So there are two approaches here. You can see A and B. And the proper approach to do a bursectomy is the approach on the right, which is B, where we lift the greater omentum superiorly, and then we go divide into that avascular plane between the colon and the back of the omentum. And that thin layer of peritoneum is suspected to have a lot of lymphatic vessels and may contribute to the local recurrence. And that's the kind of the Japanese way of doing the bursectomy, is going in that avascular plane all the way to the pancreas and back in the superior aspect of the pancreas up until you meet the caudate lobe of the liver, and then shave that and then go backwards and stop. And that would be the whole, this is called the bursa, which is basically the lesser sac. But they want to excise all the surroundings of that lesser sac. The dissection starts in that manner, is taken. I'm going to show these pictures, but we're going to go back and show more pictures. But this is just to show a picture after the stomach has been lifted and bursectomy, and you can see the middle colic vein running in the transverse mesocolon to reach or to become the superior mesenteric vein. And you can see how skeletonized it is with no covering, no peritoneal covering anymore because of a proper right bursectomy that has been done. And a similar picture here. This shows some of the dissection. You can see the stomach reflected upwards, and we can see the left gastric vessel and the skeletonization of the root of the left gastric vessel from the celiac axis, and then dividing it. And the most important thing is removing all those fat planes on the right and left of the left gastric vessel. This is group 7 lymph nodes. And on the picture on the right, we can see continued skeletonization. We can see here the common hepatic and all the fatty tissue above the common hepatic have been removed, and we can see the gastroduodenal vessels. This is a picture after a full dissection. We can see here the pancreas, the head of the pancreas, the neck, and the body. And we can see here the splenic artery. You can see the common hepatic and the left gastric has been removed. This is right prior to getting the D2, which is this group of celiac lymph nodes and this group of splenic artery lymph nodes to complete the D2. This is picture of the final specimen of a subtotal gastrectomy. As I was saying, did the D2 gastrectomy deliver in terms of survival? And the answer is yes. The two main trials are the top two trials, the MRC, which is a British trial, and then the Dutch trial. Both of those showed equivalent mortality and morbidity between the D1 and D2, like showed that D2 is doable without killing more people or making them sicker. But at the same time, when compared on a 5-year survival, we could see significantly that those cases done in Japan, and maybe this slide came a little bit out of order, but the survival in Japan for a stage 1A is a 5-year survival is 95%, while in the USA it's 78. Go down to stage 3B, you'd find it 35 versus 8. It has been significant throughout, kind of making the argument for a more extensive lymphadenectomy. The people in the West here try to argue with the Japanese data, saying, oh, they have better data because they have a different biological behavior tumor, stage migration because they do more lymphadenectomy, they get more accurate N staging, and therefore they can give better treatment, but it's not really a better operation. And then technical factors. I don't know if any of the faculty has been to Japan, but the assistants in Japan are the professors. There is, like in every institution, in the Tokyo Cancer Institute, you'd find 1 or 2 main surgeons and a team of professors assisting that main surgeon. It takes years for someone to become the primary or the main surgeon because of the extensive time spent dissecting and skeletonizing those vessels, and also the centralization of that care in that country, which makes the skill of the operating surgeon extensive. In addition, the veracity of reports. Some people commented on the MRC and the Dutch trial that not every hospital that joined into that trial did the same lymphadenectomy, and therefore the results cannot be extrapolated in a similar manner because not all of them were considered D2 gastrectomy. As I was alluding, the morbidity mortality was not different. However, we can see the overall survival of all comers in the MRC was 33%. The Dutch trial with a D2 gastrectomy was 47%, while later on studies in the United States and Memorial Sloan Kettering showed even survival of almost 80%. Obviously, that was attributed more to patient selection rather than, and also they had supervisors come from Japan to supervise the integrity of the surgical technique, because you cannot claim a result for D2 gastrectomy unless you followed the exact surgical technique. It happens to be that for males, mortality was found to be more. However, survival was no different. While in females, survival was improved with a D2 gastrectomy. They have done a 15-year follow-up for the Dutch trial, and they found that those differences went away. And the only thing that stayed, that the D2 gastrectomy had a better survival. Those were the original results, that the D2 were not proven because it's a technically demanding operation. At the time, they used to do splenectomies at the same time they're doing the lymphadenectomy, and that ended up with more morbidity for the patients. Later on in the 15-year follow-up, they had stopped doing the splenectomies, and that actually improved the results. And I'm going to show this is the 15-year follow-up of the MRC trial. You can see the 5-year survival point. It wasn't much different, and at the time they said survival is not different. But by the time the learning curve of the lymphadenectomy and doing it accurately under supervision was done, up to 15 years, you can see that there is a significant difference between those who had a D2 gastric lymphadenectomy and those who had a D1 lymphadenectomy. Therefore, that says that local control is essential. We can achieve that with the D2 lymphadenectomy. Additional trials were done, like the intergroup 116, which is a SWOG trial here in the United States, and it did show that the D2 improved survival, and it also showed that it can absolve us from using post-operative radiation. If you've done a D2 gastrectomy, you don't necessarily need to do post-operative radiation. These are some of the figures, and I'm going to flip between the D1 and D2, and you can see the D2 showing much better survival than the D1, which is lower, and each one shows whether or not they got chemotherapy. So the best combination basically is neoadjuvant chemotherapy followed by gastrectomy and D2 lymphadenectomy. We spoke about this. And we spoke about this too. I just said those. No benefit for chemoradiation after a D2 gastrectomy. It basically achieves the local control that is needed. So why is, like countries with low incidence of gastric cancer, why don't we do a proper D2 lymphadenectomy? It's not considered standard of care. People still remove the stomach with some fat around it, and that applies to rural hospitals in the United States and England, as opposed to the major cancer centers. They which basically the people doing the surgery, as yourself, are highly trained, specialized surgical oncologists, as opposed to the general surgeon who may have trained at a time that they didn't take notice of the importance of a proper lymphadenectomy. The problem is that the majority of the cases for gastrectomy are not done in the specialized centers. They're done in the outside facilities, and therefore 50% of those or more are inadequate resections. And also the surgeons or the residents training in those hospitals see fewer cases than what's enough to develop the skill to do it efficiently. For example, in the States, we have 21,000 cases a year. An example, like in Texas, only 2 hospitals can do more than 20 gastrectomies with D2 lymphadenectomies per year, while in Massachusetts, 3 hospitals have residents who have more than 10 gastrectomies during their 5 years of training. So the problem is training on D2 lymphadenectomy has become an issue, and therefore the overall outcome of the treating the disease has gone down or is not up to standard. There are some additional concepts in the last few meetings and have been discussed and now are being included in the NCCN guidelines for this. Recently, with the growth of minimally invasive gastrectomies, lymphadenectomies are done more laparoscopic and robotic. Initially, there was an argument that they don't harvest enough lymph nodes, but now with more recent studies and with the growth of the learning curve, we can see that the minimally invasive have similar lymph node yield. Another concept, the ratio of positive to harvested lymph nodes, that is now being looked upon to predict prognosis and to decide on further treatment. As I said before, PD-1 checkpoint inhibitors and trials right now, PD-1 inhibitors or blockers are used as a second line for metastatic disease, but I'm sure you heard about the recent New England Journal of Medicine paper about colon cancer with the mutations where a PD-1 checkpoint inhibitor was used and caused complete pathological response in 100% of the patients that it was used on. So there is more to come down that route. As I said, the HER2 status and H. pylori, now Herceptin is being used as neoadjuvant treatment for gastric cancer in HER2 positive patients, and H. pylori eradication is becoming more and more important. And the sentinel lymph node mapping, as I said, if in early gastric cancer, precision lymphadenectomy would be considered. Finally, I'm going to go over the technique for a D2 lymphadenectomy. I'm going to show pictures and we'll talk over the pictures. But I also listed about 5 or 6 slides, a description of the technique. I got that from one of the Italian papers, and I modified some of it based on what is being recommended and done. For a D2 gastrectomy or a gastrectomy with D2 lymphadenectomy, we use an upper midline, mobilize the left lateral segment of the liver medially, and then we start, as we said, with holding the greater omentum superiorly and finding the avascular plane between the greater omentum and the transverse colon. That avascular plane is the plane of vessels. Basically, if we follow that, it doesn't even need cautery or anything. Just with the back of a forceps, we can dissect that down the middle colic, down all the way to the SMA, all the way to the pancreatic body, and it is carried from the hepatic flexure to the splenic flexure all the way. We mobilize the flexures because we need all the omentum attached to those. On the left side, we start by cutting the left gastroepiploic artery and vein at their origin from the splenic vessels, allowing removal of the beginning of station 4. Station 4, as we said, is the whole greater curvature. It starts with SA, SB, and D. SA are the ones on the short gastric vessels. SB is the left gastroepiploic, and that's why we start with it. So this description goes more with a subtotal gastrectomy, that we're going to leave the short gastric supplying the fundus of the stomach and take it from the origin of the left gastroepiploic down. We complete a bursectomy, like I showed in the figures before, to remove all the layers surrounding the lesser sac. And then we go above the stomach, open the lesser omentum, and then we reflect the stomach upwards. The next step would be a picture like this. We see all the vessels supplying the whole area of the pancreas. We had already divided the left gastroepiploic at origin from the splenic. And then we start picking on what lymph nodes are we going to do. We start on, we divided this, we got the 4 SB. If we're going to do a total gastrectomy, then we go upwards and we get the 4 SA. And the best way to do it is to divide the vessels as close as possible to the spleen, but with identification of the vessels, so we can get the lymph nodes with them without injury of the spleen. And then we can take this dissection all the way to this point, and then we go back the other way. The other way, we divide all the attachments between the right gastroepiploic and the pancreas. We lift it up all the way to the pylorus until the right gastroepiploic artery and vein are identified, and those are dissected down to the gastroduodenal, so we can remove all the fat tissue around that group. So if you may, we're going in a clockwise direction. Like we started here, we go down, we take all these groups, and then we go above the pylorus. And at that point, we take group 5, which is on the right gastric. And you can see here dividing the right gastric at origin from the hepatic artery. And then we move up the lesser curvature all the way to group 1. Once we reach group 1, we clean up the lesser curvature, depending on what we're doing. If we're doing a total gastrectomy, then we're going to be dividing the lower esophagus here and then going across and getting group 2 with us. If we're doing a subtotal, then we don't need to take out this group or this group of lymph nodes, because we're going to be dividing the stomach along a line in this plane. But we take all group 3, which is 3A and 3B. Once we've done that, with the stomach reflected, I'm going to go to the previous picture. With the stomach reflected like this, we identify the left gastric artery, and we skeletonize it here, and we divide it at its base, at its connection with the celiac artery. You leave 1 centimeter, you're going to leave perivascular tissue that has lymphoid tissue that's likely to be the site of local recurrence in the future. So the best is to do it straight flush on the celiac artery. Once that has been done, then we finished the D1 part of the D2. Then we go to the more extensive lymph nodes, which is basically we dissect around the celiac axis. Now we have the origin of the splenic and the origin of the common hepatic here. There is a bunch of fat to the right of the celiac axis. That's group 9 and group 8. And then there is a bunch on the left aspect, just above the splenic vessel. And that is also part of group 9, but can also go to group 10, which is the continuation of the splenic hilum. And then we have 11P along the way. Here is basically 11P, and then it becomes 10. And those are the more extensive groups. Again, then we go backwards on the common hepatic. We remove the bunch of fat here, and the limit for dissection is to keep doing it until you see portal vein behind the hepatic artery. Then you go up the hepatic artery proper, and that's almost the hilum of the liver, the anterior group of lymph nodes, which is group 12A. The Japanese surgeons used to have a specific surgeon sitting next to the table on a separate table with a box, like the drug box, which have like 20 different slots, and they would get all those lymph nodes and they would divide them. This is the slot for group 1, this is 2, this is 3A, 3B, and they keep doing this to correlate with the pathological evaluation of the tumor, like which tumors sent metastasis to which lymph nodes. Anyhow, we continued group 8. We went up the hepatic artery proper, and we removed group 12A. That leaves only one group if we have to, if there is like enlarged lymph nodes. Let's say we are dissecting in this area in the hilum, and there are enlarged lymph nodes in the hilum. There is a technique called Genet technique, where we basically mobilize the spleen, mobilize the tail of the pancreas, and we reflect them medially, and then we can access the lymph nodes that are behind the splenic artery at that point, and that finishes group 10. Some people go to more groups which are down the superior mesenteric, like 14, the group 14 or group 16. I wouldn't advise, and I'm not sure if you agree with that, but it's if you have to dissect down to that level, it's already like the genie is out of the bottle, like they say. It's already a too advanced tumor to do this, and that basically completes the division line. Is here. There is a line that there is a point between the meeting of group 4A and 4B with group 4D. This is called the Van Gotham point, and that's basically the best point to divide. Now, if the tumor, if you need 6 centimeters proximal and that passes this tumor, then you can do that and divide higher, so you can reach a good 6 centimeter, but you have to make sure that you removed all this group of lymph nodes in all cases. If you're going subtotal, and if you're doing a total, then as we said, you're going to go all the way around. This is basically what I have, and this is the technique. As I said, I specified, like I wrote it down per group, going one station after the next, and also some considerations for laparoscopic, because now we're doing more laparoscopic and robotic resections. And that's all I have. And thank you very much, and happy to take any of your questions.
Thank you, Dr. Danny, for this informative talk. We can now start taking questions from the audience. Please, if you have a question, raise your hand. Dr. Fuad.
Dr. Danny, أهلا بيك. Thank you for this lecture.
Thank you, Dr. Fuad. Thank you very much.
وحشتنا فعلا بجد يعني.
الله
نتكلم
يخليك.
عربي شوية.
الله يخليك.
بعد إذن الشام يعني.
No.
Is it routine in doing gastrectomy? Do you remove the anterior layer, the posterior layer of the laser sac on front of the body of the pancreas?
So that's the part that I was describing as the bursectomy. You see, this is like the whole thing about D2 gastrectomy and bursectomy and such is a concept of how aggressive you want to be. In reality, I gauge that per patient. Like if I have an 80 years old patient who have a gastric cancer and it's like a T2, or a T2 is only one enlarged lymph node and it's not a diffuse type, then I'm going to do a D2, but I'm not going to extensively do a morbid operation by shaving off the surface of the pancreas. However, if it's a young patient, and many of them are, then you do the whole 9 yards, basically.
How about the incidence of doing splenectomy in the tumor of the greater curvature of the stomach?
Right. So some people consider that as part of the lymphadenectomy, to get that group, like group 11P and group 10, which is the splenic hilum. If the lymph nodes are already grossly enlarged, then splenectomy becomes a no-brainer. It has to be done as part of the lymphadenectomy, because some people say, well, let's do a spleen preserving, and they start shaving off the vessels up and down, and then you risk post-operative bleeding and other issues with the tail of the pancreas and pancreatic leaks. It may be even safer for the patient to just do the splenectomy and give them the vaccines, of course. But that's a great point. Yes.
Okay. What is the main complication you met with when you do D2 lymphadenectomy and gastric carcinoma? Main complications, mainly.
I would say if there is extension of the tumor along the lymphatics, and the lymphatics, let's say we're doing the group 8 that's around the common hepatic artery, and it's creeping up to the hepatic hilum, and we persist and persevere, and we try to skeletonize the vessels. Sometimes you can skeletonize them to the point that they become so thin, or you try to go posteriorly enough and you could nick or like touch the portal vein. So in extensive tumors, you could risk a major bleeding if you persevere on it. However, that's an assessment with experience. Like when you go in, you feel with your hand and you say, oh, this is moving and I can move it on the portal vein, then I can dissect it off the portal vein. Sometimes you have to compromise and leave a millimeter of tissue on the artery or vein and put clips and hope for the patient to get radiation after.
Okay, thank you, Dr. Danny. Thank you for this. Thank you.
Okay, thank you, Dr. Fred. Do you have any other questions? Dr. Medhat Khafaga, you have a question? Yes. If you have a question, please raise your hand.
Okay, I'm talking. Thank you, Dr. Danny. Yakoub.
Thank you, Dr. Khafagi.
How about if you find that tumor is involving the overlying serosa, do you go ahead with a D2 gastrectomy?
Absolutely.
Yes,
Absolutely.
it's one thing. You don't think that 10% of postoperative mortality is high? The results you showed 10 to 12% mortality, which is very, very
That's
high.
because that's in that studies were done at Memorial or the major cancer centers. They don't turn anyone back, and I agree that's a high mortality percentage. It should be somewhere between 2 and 5%, and that's the acceptable number, and therefore appropriate preoperative assessment and judgment during surgery. Gastric cancer can be as bad as pancreatic cancer in our minds, despite that we think, yeah, we can remove the stomach and it's all gone. Reality is biology is king. Which means like if it's just an extensive diffuse tumor, signet ring or otherwise, and we have multiple groups of bulky lymph nodes, we should try to do as appropriate as possible without trying to become heroic, because becoming heroic is what causes the mortality post-operative. You thin an artery, they get an aneurysm in the artery and they bleed and they die. Judicious application of the surgical technique is critical to choose the patients, and there is nothing wrong with going 3/4 of the case, and before you commit, before dividing the fundus or before dividing and that's why we try to do that stuff before we divide the stomach. So if we know we can go all the way, we go all the way. If we can't, then just do a bypass and bail out and leave.
Well, I worked at Memorial Sloan Kettering Cancer Center for 3 years.
Okay.
As the resident and fellow. It's way back. But I didn't find that mortality there. Only maybe less than 1%. I worked with Faulkner at that time. The mortality, I didn't, for 6 months in gastric and mixed tumor, I don't remember a single case of mortality, really. I don't know from where they get this.
I'll have to go back and review the numbers. I hope I didn't make any mistakes, but I think that was one of the criticisms on doing the D2 gastrectomies, that they get themselves in more trouble doing it. Again, the concept is not old. Like to do D2 gastrectomy for all gastric cancer comers is something that started in the late 90s to be applied appropriately. Before that, it was all D1. So the results are more of a recent account of what's happening rather than the
Also,
previous times.
There is 30 days mortality, and there is a mortality in the 2 months after the patient goes home.
Correct.
This usually because they may not eat well, and so they may pass into pneumonia or something.
Exactly, nutritional issues. Yeah.
After going home is double the mortality in the hospital.
Absolutely, absolutely. That's why part of the procedure, like in all patients, I put a feeding tube, and I sometimes put those like a feeding jejunostomy, and I put that before they go to chemotherapy, like at the staging. I do a diagnostic laparoscopy, put a port, and put a feeding jejunostomy in preparation so they can be fed before and immediately after surgery.
How about if you find that there is positive nodes in the D1 perimeter of the stomach? Do you go more to D3 or just D2?
Do you mean like gross enlargement?
If there is gross involvement of D2 lymph nodes, and also another possibility of there is gross involvement D2 lymph nodes. You go higher up.
Right. I don't believe past D2. I would finish my D2 procedure and then make sure I put clips at all the lymph node stations that I think were closest to the grossly enlarged lymph nodes, and then arrange for post-operative chemoradiation.
Okay, thank you.
Pleasure.
We have a question from Dr. Haitham.
Yeah, hello everyone. Hello everyone. I have
Hi.
many questions that have nothing directly to do with lymphadenectomy. Am I allowed to ask them?
Of
Like,
course,
for
of course.
example, what is, in your opinion, the role of pieback or HIBIC in gastric cancer?
That's a great question. Right now, it's all trials.
Okay.
Trials and anecdotal experience. Some center would have done like 20, 30 cases. I think HIPIC would have a role only after the cancer have stood the test of time, meaning we've done the treatment, neoadjuvant chemotherapy, we've done the surgery to the best of our ability. And then the patient came back with or had like involvement of peritoneum at the time. I think they should be put on systemic chemotherapy for a while. If no new lesions occur and no progression, we can try HIPIC as to kind of kill or remove the residuals. I think Mayo Clinic Rochester right now have a trial for the same for pancreatic cancer, where they do it even in those with positive peritoneal cytology before chemotherapy, and they do HIPIC, and then they give the patient some time on chemotherapy and then do it. The same has not been applied yet to gastric cancer, but just like metastasectomy and liver resection for liver metastasis, only if it's a very few lesions which stood the test of time, like 6 to 9 months with no progression, then we can try to approach those. Again, on a case-to-case basis and not to be taken as a guideline.
Okay, and what about pieback as a palliative procedure for patients with peritoneal metastasis?
The causes of death are usually visceral metastasis. It's very rare to find peritoneal metastasis without visceral metastasis, which are the main cause of mortality. So you're going to treat the peritoneal metastasis and then the patient will die anyway from other systemic spread.
Okay. I have another question about IEG tumor 2, IEG. You know,
Gastroesophageal junction tumor.
Yeah, type 2.
Seward 2. Okay.
Seward 2, of course. Yeah, yes, that's great. Seward 2. What's your opinion? Should be transhiatal from the abdomen or should undergo Ivan Lewis operation?
Well, I love that question because I myself am more aggressive with it. I think that first of all, it has to be subject to diagnostic laparoscopy, peritoneal washings, and neoadjuvant chemotherapy for sure. The question is when we treat it. Now, the tumor is rarely a spot. It's usually a few centimeters. So I usually go by which few centimeters. Is it going more up and the center is down, or is it going more down and the center is up? Total gastrectomy is a morbid procedure. And I dare say that a transhiatal esophagectomy is a nicer functional operation than total gastrectomy. But not everyone will listen to this because most of those who can do a gastrectomy cannot do an esophagectomy. And most of those who do esophagectomy cannot do a gastrectomy. Like lots of thoracic surgeons do esophagectomies, so they're happy to do it, while surgical oncologists and general surgeons usually do the total gastrectomy. When you're trained to do both and you can get good outcomes, good surgical outcomes with both, you're going to end up like myself. I mean, I don't think it has been studied, but like myself, I can get a patient back to normal functional level in terms of eating, in terms of swallowing with a transhiatal esophagectomy than that with a total gastrectomy. Is the answer because of the other functions of the stomach, like the hormonal functions or whatever? I don't know. the answer to that. But in my mind, if I have the choice, if I have equal chances for both, I do a transhiatal esophagectomy.
And what about the oncological result?
Well, the oncological results with a transhiatal esophagectomy, believe it or not, I do a D2, except for the area of the spleen and the splenic artery. But I always remove the whole lesser curvature. I remove group 5, I go to group 7, 9, 8A, and 12A. I clean those with every junctional tumor.
But you leave 4 behind, 4 and 6, right?
Say that again. I leave 4 and 6 because those are
behind.
those are the greater curvature. Yes.
Okay. Okay. Thank you.
Okay, we have a question from Dr. Gamal Amira.
Thank you for the lecture. My question is, what is your indications for neoadjuvant chemotherapy in different parts of the stomach?
So, classically speaking, if we're gonna go over the details of the MAGIC trial, which said that people get chemotherapy are better than chemotherapy plus surgery is better than surgery alone. Most of the patients included in the MAGIC trial had proximal tumors. And therefore, there are still practitioners that say, oh, antral tumors, we can go surgery first and then chemotherapy. But the reality is, that's not why we're giving the chemotherapy. We're giving the chemotherapy because of the propensity of micrometastasis, of, if you may, circulating tumor cells. And that's no different between fundus tumors and antral tumors. So my indications, anything beyond T1B should get neoadjuvant chemotherapy if the patient is relatively young and can tolerate. I also don't want to give an older patient chemotherapy, knock them down, and then they can't do the surgery, which is the final curative step. So there has to be an assessment of frailty. There are now many frailty indices, like a frailty index or the Eastern Cooperative Group functionality. There are scores that you can give to the patient. Can they tolerate chemo successfully and make it to surgery, or is it better to start with surgery and then see if they can tolerate chemo? Because the results with surgery alone will be better than the results with chemo alone. The best results, chemo plus surgery. Again, if it's a T1A and T1B, and in your institution you have the facility to do an EMR or ESD, then those should be done, because those are not final. You can always come back and do a gastrectomy if there is a recurrence or such. But I would give chemotherapy to all locations if I can.
Yes, if you have a pyloric obstruction and you need to give neoadjuvant, do you do at this time feeding jejunostomy or no?
Well, I think with pyloric obstruction, your hands are tied. You're going to have to operate to resolve the obstruction. Either you're going to do a bypass and give chemotherapy, or you're going to resect and reconstruct. Obviously, that's not a good option, because the results of resection as an emergency basis is not as good as if it's elective. So let's talk about, if you're not going to resect, you're going to bypass. I always put a gastrojejunostomy tube through the surgical gastrojejunostomy, because the pyloric obstruction would have been there for days, weeks, or months, and they end up with an atonic stomach. So even once you do the gastrojejunostomy, it doesn't drain well. So I like to put a gastrojejunostomy tube through, like a gastrostomy with a jejunostomy extension, through the anastomosis to feed until the stomach gets back its motility, if that's what you're asking.
Thanks. Thank you.
Thank you, sir.
Okay, thank you, Dr. Danny. I think we don't have any more questions. It was a pleasure to have you with us. We have one more question, actually. We'll take one last question.
Okay.
For Mustafa. So Mustafa, please unmute and ask your question. Okay, I think it's not working.
Happy to take any questions by email. If you text me, I'll text you my email, and happy to take any questions anytime.
Okay. Thank you, Dr. Daniel. It was a pleasure having you and looking forward to your next webinar, inshallah.
Thank you very
Okay.
much. It's been a pleasure.
Okay, good night, everyone. Next week, there will be no webinar, but in 2 weeks, we have Dr. Olivier Glehan. So see you in 2 weeks. Thank you.
Thank you.
Bye-bye.